Welcome to This Week in Pulmonary. This week we're covering 8 notable papers spanning advanced diagnostics in pulmonary vascular disease, optimizing management in chronic airway diseases like chronic obstructive pulmonary disease and cystic fibrosis, and critical evaluations of therapeutic interventions in the intensive care unit and interstitial lung disease. Let's dive in. We begin this week with major developments in how we diagnose and risk stratify pulmonary vascular conditions, specifically focusing on suspected pulmonary embolism in cancer patients, and the non-invasive identification of exercise-induced pulmonary hypertension. For years, clinicians have struggled with the diagnostic workup of suspected pulmonary embolism in patients with active cancer, as current guidelines often suggest proceeding directly to computed tomographic pulmonary angiography, or CTPA, due to fears of missing a clot in this highly prothrombotic population. However, the HYDRA study, a randomized open-label trial, challenges this aggressive approach by evaluating the safety and efficiency of the year's diagnostic algorithm. This multi-center trial across 21 European hospitals randomized 698 active cancer patients with suspected pulmonary embolism to either diagnostic management guided by the year's algorithm or direct CTPA. The year's algorithm utilizes 3 clinical items: clinical signs of deep vein thrombosis, hemoptysis, and whether pulmonary embolism is the most likely diagnosis, along with adjusted D-dimer thresholds to determine the need for imaging. The primary outcome was centrally adjudicated symptomatic venous thromboembolism, or pulmonary embolism-related death within 90 days. Remarkably, only 1.8% of patients in the per-protocol years group experienced a primary outcome compared to 5.5% in the per-protocol CTPA-only group, successfully demonstrating non-inferiority. Crucially, using the year's algorithm allowed clinicians to safely avoid CTPA in 22% of the patients, significantly reducing radiation and contrast exposure without compromising patient safety. This provides strong, high-quality evidence that we can safely apply structured clinical algorithms to rule out pulmonary embolism in patients with active cancer. In a parallel effort to refine diagnostics in pulmonary vascular disease, a prospective study published in Respiratory Research addresses the challenge of identifying exercise-induced pulmonary hypertension, or EIPH. This condition represents an early, potentially modifiable stage of pulmonary vascular disease that is notoriously difficult to diagnose non-invasively, especially in patients with borderline resting hemodynamics. The investigators developed and validated a multimodal model that integrates clinical characteristics, exercise echocardiography, and cardiopulmonary exercise testing, or CPET, in 78 adult patients. All patients underwent these non-invasive tests simultaneously with the gold standard of invasive exercise right heart catheterization. The combined multimodal model achieved an outstanding area under the curve of 0.951 and an accuracy of 87%, which was significantly superior to any of the individual testing modalities alone. This highlights that combining clinical, echocardiographic, and metabolic parameters provides a highly reliable non-invasive pathway to identify early pulmonary vascular disease, offering a practical alternative to invasive catheterization for monitoring high-risk patients. Next, we turn our attention to chronic airway diseases, where new research is reshaping how we manage chronic obstructive pulmonary disease, or COPD, and conceptualize ongoing disease in cystic fibrosis. In the realm of COPD, a pooled analysis of 6 observational studies published in the International Journal of Chronic Obstructive Pulmonary Disease evaluated the real-world safety and effectiveness of extrafine single-inhaler triple therapy, consisting of beclomethasone, formoterol, and glycopyrronium. This study of over 5,000 patients specifically focused on vulnerable subgroups with multiple comorbidities or established cardiovascular risk, who are often excluded from randomized controlled trials. The researchers found that initiation of this extrafine triple therapy led to significant improvements in COPD assessment test scores and lung function across all subgroups. Most patients remained entirely free of exacerbations over 12 months, and there was no increase in long-term cardiopulmonary adverse events, confirming that triple therapy is both safe and highly effective in medically complex patients. The clinical trajectory of COPD is further explored in a prospective observational study in Respiratory Research, which examined the impact of immediate same-day treatment of acute exacerbations. observing 57 patients who developed an exacerbation while undergoing a closely supervised 4-week inpatient pulmonary rehabilitation program. The researchers evaluated the clinical course when systemic corticosteroids or antibiotics were initiated on the very day of symptom onset. On the first day of the exacerbation, patients experience a significant decline in lung function and a sharp rise in C-reactive protein. However, with immediate intervention and continued adapted physical activity, both lung function and inflammatory markers completely normalized by day 5. By the time of discharge, patients actually demonstrated significant improvements in their symptom scores, 6-minute walk distance, and muscle strength compared to their pre-exacerbation baseline. This suggests that the prolonged, incomplete recovery typically associated with COPD exacerbations in outpatient settings is not inevitable. Rather, immediate treatment combined with structured physical rehabilitation can dramatically accelerate recovery and preserve functional capacity. Meanwhile, the therapeutic landscape of cystic fibrosis has been completely transformed by CFTR modulators. Yet a review in the American Journal of Respiratory and Critical Care Medicine reminds us that clinical triumph does not mean complete cure. The authors introduce a novel conceptual framework termed residual disease activity, or RDA, to describe the ongoing subclinical pathological processes that persist despite modulator therapy. Even when patients experience unprecedented gains in lung function, many continue to exhibit persistent abnormalities in mucus viscosity, mucociliary clearance, chronic airway infection, and low-grade inflammation. The paper argues that as the cystic fibrosis population ages, clinicians and researchers must move beyond traditional measures like forced expiratory volume in 1 second and instead systematically evaluate these residual disease domains. This framework will be vital for designing future clinical trials and tailoring individualized monitoring strategies to prevent long-term irreversible lung damage. Our final theme this week critically examines therapeutic interventions in both chronic interstitial lung disease and acute critical illness, challenging some long-held clinical assumptions. In interstitial lung disease, a major study published in the American Journal of Respiratory and Critical Care Medicine evaluated the long-term impact of immunosuppression with mycophenolate or azathioprine in non-idiopathic pulmonary fibrosis, fibrotic interstitial lung diseases. This multi-center retrospective study of over 2,000 patients utilized an advanced clone sensor weighting framework to emulate a randomized controlled trial, adjusting for baseline characteristics and treatment changes over time. Surprisingly, the initiation of immunosuppression within 6 months of enrollment was not associated with any improvement in 3-year transplant-free survival or lung function trajectory in any of the studied subtypes, which included non-IPF idiopathic interstitial pneumonia, fibrotic hypersensitivity pneumonitis, and connective tissue disease-associated interstitial lung disease. Even more concerning, immunosuppression was associated with significantly worse survival in patients with non-IPF idiopathic interstitial pneumonia, where the risk of death increased by 38%, and in fibrotic hypersensitivity pneumonitis, where the risk of death increased by 62%. These findings represent a major clinical warning, suggesting that routine, early immunosuppression in these specific fibrotic subtypes may do more harm than good, and highlights the urgent need for prospective randomized trials to guide our practice. Moving into the intensive care unit, the Nexus trial evaluated whether an early aggressive rehabilitation and nutritional intervention could improve physical outcomes in patients with acute respiratory failure. This multi-center phase 2 trial randomized 115 critically ill, mostly mechanically ventilated patients to either standard usual care or an intensive protocol consisting of 45 minutes of daily in-bed cycling, combined with intravenous amino acid supplementation to target a high protein intake. While the intervention group successfully achieved the targeted exercise duration and a near doubling of protein intake, there was no significant difference in the primary outcome of 6-minute walk distance at hospital discharge, which was 108 meters in the intervention group, compared to 95 meters in the control group. Secondary functional outcomes and 6-month follow-up surveys were also similar between the groups, demonstrating that while early mobility and aggressive nutritional support are safe, this specific combined protocol does not translate into measurable functional recovery. However, the way we approach nutrition in the intensive care unit may soon become more personalized, as demonstrated by a secondary analysis of the EDEN trial also. The original EDEN trial found no difference in mortality between trophic and full enteral nutrition in patients with acute respiratory distress syndrome, or ARDS. In this secondary analysis of 889 participants, researchers investigated whether circulating intestine-derived incretin hormones could predict which patients benefit from specific feeding strategies. They discovered that baseline levels of glucose-dependent insulinotropic peptide, or GIP, significantly predicted a heterogeneity of treatment effect. Specifically, patients in the highest third of GIP levels had a clinical mortality rate of only 14.1% when randomized to trophic feeds, compared to 27.2% when given full enteral nutrition. This interaction was not seen with GLP-1 or other baseline risk profiles, suggesting that GIP could serve as a unique, highly specific biomarker to guide personalized enteral nutrition strategies in critically ill patients. If you only have time for one paper this week, make it the HYDRA study. This landmark randomized trial provides the high-quality evidence we have desperately needed to safely implement the year's diagnostic algorithm in patients with active cancer, proving that we can safely spare nearly a quarter of these vulnerable patients from unnecessary CT scans without compromising safety. Here are the key takeaways from this week in pulmonary. First, the year's diagnostic algorithm can be safely applied to patients with active cancer and suspected pulmonary embolism, reducing unnecessary CTPA imaging by 22%. Second, routine early immunosuppression with mycophenolate or azathioprine in patients with non-IPF idiopathic interstitial pneumonia and fibrotic hypersensitivity. Pneumonitis is associated with worse survival and no lung function benefit, necessitating a highly cautious approach. Third, combining clinical data, exercise echocardiography, and cardiopulmonary exercise testing yields an exceptionally accurate non-invasive method to identify exercise-induced pulmonary hypertension in patients with borderline hemodynamics. Fourth, same-day initiation of guideline-based therapy for acute COPD exacerbations combined with continued physical activity during rehabilitation leads to rapid recovery of lung function and inflammatory markers within 5 days. Finally, baseline levels of the incretin hormone GIP may help personalize nutrition in ARDS, identifying a subset of patients who experience significantly lower mortality with trophic rather than full enteral feeds. That's your roundup for this week in pulmonary. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence which can make mistakes. Always review the original source materials.